All right. Well, good afternoon, everyone. You're having a happy fall and a good Friday the 13th. Uh, we're gonna have a good conversation this afternoon or morning, depending on where you're joining from. I'm Brandon Garrett with the National Minority Equality Forum. We're gonna have Ms. Victoria Kennedy of CALAR, the Executive Director for Oncology Patient Engagement for CALAR Communications Global, lead us in this webinar on improving our understanding of triple negative breast cancer to advance health equity. So without further ado, Ms. Kennedy, tell everybody a little bit about yourself, since I think this is your first time hosting here, and about today's panel.
Great. Thank you so much, Brandon. It's a delight to be here today on this beautiful Friday, Fall Friday. I'm Ricki Kennedy. I am, as Brandon mentioned, with CALAR Communications. I'm actually an oncology social worker, and I've been in oncology now for almost 40 years and have worked at the bedside and with an organization called the Cancer Support Community, and have near and dear to my heart is the passion that the advocacy community brings to solving complex patient care and access issues. And in particular, as we talk today about gaining a better understanding of triple negative breast cancer and what is the greatest challenge that we face, and really a call to urgency. So it's a thrill to be here with this amazing panel that we have with us today. You know, we're celebrating, as you all know, Breast Cancer Awareness Month. It's you can hardly turn anywhere. We have some beautiful pink with some of our panelists today, and of course, but sadly, for many people facing triple negative breast cancer or metastatic breast cancer, it's a painful reminder that there are limited treatment options, that there are, they sometimes feel disconnected from the celebratory pink world because as for many breast cancer patients, it's a 365-day-a-year experience, not just the 31. But, you know, we are here to really celebrate some advances that have been made in triple negative breast cancer. My own sister-in-law died of triple negative breast cancer over 23 years ago after the birth of her third child. And we knew nothing. We didn't even know it was triple, there was so much we did not know or understand. So significant progress has been made, especially in the last 10 years, where, really, there was a point where we had, few doctors who had experience in caring for women who were diagnosed and really no targeted treatments. But yet, despite these incredible strides, the risk for women diagnosed with triple negative breast cancer is greater than those diagnosed with other types of breast cancer. And I think it's important today for people to leave this session with a better understanding that there is not just one type of breast cancer, and that we know so much more, even with lung cancer today, about the many various subtypes. And that means that we are really going to, and I think you're going to hear time and time again in this session, that there's much more work to be done, even though we've made progress. But there's more work that needs to be done to improve outcomes for all women diagnosed with triple negative breast cancer. And much of it is rooted in reducing the health inequities and remaining steadfast to research and innovation. So we have these great panelists today. We're going to jump right in here pretty soon, but we have three primary aims with our conversation today. We want to describe the disproportionate impact of breast cancer on Black, Hispanic, Latina, and young women, and why delays in screening and diagnosis are exceptionally devastating for those at greatest risk for triple negative breast cancer. Secondly, we want to illustrate the importance of data. We need better data to inform decision-making and to really document the urgency for investment in drug discovery of innovative treatments for individuals impacted by triple negative breast cancer. And thirdly, we want to demonstrate the importance of advancing policies that could protect or better protect underinvested communities that are disproportionately impacted by cancer. I'd like to quickly introduce our amazing panelists we have here today. I think you're going to be just really impressed with not only their knowledge and expertise, but the deep passion that they have for this work. First, I'd like to introduce Ricki Fairley, who is a TNBC survivor, CEO of Touch, the Black Breast Cancer Foundation. Ricki, you're looking smashing today in your pink dress and earrings. Thank you so much. And Ricki is an outspoken advocate. I don't know how you do it all. Not only running this organization, but being on the Hill and working in policy and really thinking about how we can move the needle for Black women with breast cancer. She is the founder of the #WhenWeTrial movement, and I think you'll hear more about that today, and co-host of The Doctor Is In, a weekly web series that airs on blackdoctor.org, which is a Facebook page that reaches over 3 million people annually. And she's also founding member of #BlackDataMatters. And again, an important, as I mentioned, one of our second aim today is really focusing in on the importance of data and how we need more. I'd like to introduce Dr. Elizabeth Valencia. She is an expert consultant in breast imaging and intervention with the Department of Radiology at the Mayo Clinic in Rochester, and formerly the Associate Dean of DEI at the Mayo Clinic Alex School of Medicine. She's a nationally renowned speaker on health equity, breast cancer, law and medicine, bioethics, mentorship, anti-racism, and DEI in healthcare. And we're really honored to have Dr. Valencia with us today. And we have Dr. Vivian Jolly-B, who is the section chief of breast surgical oncology at the Department of Surgery for New York Presbyterian Brooklyn Methodist Hospital. As a breast cancer disparities researcher, educator, and community outreach leader, Dr. B has focused on bridging the gap between multidisciplinary breast cancer treatment and community barriers, something you will hear throughout the session today that is a critical challenge in triple-negative breast cancer. Dr. B's dedication to community is evident in her multifaceted community outreach programs that are designed to address breast cancer disparities in Black women through increased screening, innovative community education, and navigation services. Thank you for joining us, Dr. B. And we have Dr. Catherine Lai, who is the Executive Director of Clinical Research in Oncology, responsible for overseeing TNBC research at Gilead Sciences. Dr. Lai has over 20 years of experience in healthcare as a clinician, as a public health policy leader, and a clinical researcher in the biotech and pharmaceutical industry. And she's leveraged her vast experience to help bring several new breast cancer medicines to patients. And I'm not sure I'm just going to check here to see if Dr. Davis there. Hi, Dr. Davis, welcome. We have Dr. Melissa Davis, who is the Director of Translational Genomic Medicine at Morehouse School of Medicine. She also serves as the Scientific Director of the International Center for the Study of Breast Cancer Subtypes, also known as ICSBCS, and is Associate Professor of Cell and Developmental Biology at the Department of Surgery. She has published, and I've heard you speak, Dr. Davis, groundbreaking findings that have established a new paradigm, a new lens by which we study the association of the biological factors in cancer outcomes as related to genetic ancestry. And it's brilliant work that I think will be really enriching to our conversation today. So we are going to kind of switch back and forth today through a group discussion, small group discussion, and some presentations. We can take away these slides now. And we're really honored again to be here today with these panelists. And thank you to the National Minority Equality Forum for being committed to bringing such an important session to us all today. There is a Q&A function at the bottom of your screen here. So if you have questions throughout the conversations today, please feel free to add those conversations. And we're going to kind of dig in here and get started. So our first conversation today is going to be with to really get this kind of patient/survivor and provider discussion going. So Ricki and Drs. Valencia and Dr. B, we're going to explore really triple negative breast cancer from a patient and a provider perspective. So let's start out here, Dr. B and Dr. Valencia. What is triple negative breast cancer, and why is it so hard to diagnose and treat?
Well, I'll take that. Triple negative breast cancer, the way to think about sort of describing breast cancer is we look at three important receptors. And in triple negative breast cancer, the estrogen receptor is negative, not present. The progesterone receptor is also negative, and the HER2 new protein is negative. And so those three important factors sort of build up the triple negative breast cancer or lead up to triple negative breast cancer. And in physicians, we usually document triple negative breast cancer just as that, or sometimes you'll see TNBC, especially on social media. There's, hashtag TNBC, that means triple negative breast cancer. Now, it's important to note that triple negative breast cancer accounts for approximately 10 to 20% of all breast cancers that are diagnosed. And if you can imagine the two receptors in one protein, there are multiple sort of ways of combining those. We have hormone positive breast cancers, we have HER2 positive breast cancers. But for the sake of this presentation, we're talking about triple negative breast cancer. And the reason being is because it is an aggressive breast cancer. Just some statistics for you to know. More women who are younger than the age of 40 are diagnosed with triple negative breast cancer. It is 3 times higher in Black women compared to white women, which is concerning. We'll talk a little bit about that later. You'll learn about why that's concerning later. It's also more common in women who are found to have a germline BRCA1 mutation. And it's more aggressive, as I've said earlier. And so when you have a more aggressive breast cancer, there are a couple of things. One is it is challenging when it is diagnosed in women who are younger than 40. And I think we're going to talk about screening guidelines and sort of why that's challenging, because if it's aggressive, then we likely will diagnose that patient at a later stage, which kind of sets us behind. And it's more likely to recur. So that's sort of another important fact for triple negative breast cancer.
Thank you, Dr. B. And I will go ahead and share that along with that, we're seeing it in 15 to 20% of all newly diagnosed breast cancers in the country. And as you heard, it's most likely to be presenting in Black women. Also want to expand the conversation in that it also impacts the Latinx community as well. 15 to 33% of breast cancer in the Latino community is triple negative. And similar to anyone affected by triple negative breast cancer, it's occurring about 10 to 11 years younger than your average breast cancer. So it's not occurring in so much the women that are 40s, but it's happening in their 30s and even younger. And the prognosis is not good because we don't have treatments that target this breast cancer well. And the evolution of our ability to diagnose triple negative breast cancer and then treat it when it doesn't have the receptors that we're used to having to target breast cancer, that learning curve is really been flatlined over the last 30 years, so much that while you'll hear that screening mammography, getting a screening mammogram has reduced the death rate by 40% over the last 30 years, that has not been the case for many diverse communities, in particular for the Black community, for the Latinx community, the Indigenous and Native communities, and so on, and that they're not experiencing a 40% reduction over the last 30 years for breast cancer. It's half that. And so we have a long way to go, and that is the whole importance of this conversation, and with NMQF leading this dialogue so that we can pull together our expertise and find a better way to move forward together to really change the experience for all communities, and have the equity for breast cancer, and in particular triple negative breast cancer, because the prognosis is poor. Even at 5 years, there's a 25% survival rate, and we haven't seen that needle move in decades. And so that is what the impact is from the medical perspective.
Yeah, I'm wondering, Ricki, as you listen to this and you think about all your work, could you add to that kind of how Black breast cancer is different, and what are some of the barriers for Black Latina women or young women accessing quality breast cancer care?
Sure. Well, I'm a miracle, and this is my God job. Says I'm a 12-year survivor. My doctor gave me 2 years to live, and I'm on 12. I took a lot of experimental drugs because we don't have drugs. And I think as a patient, one of the biggest fear factors of having triple negative is that we don't have a drug to prevent recurrence. We're the only breast cancer that doesn't have a drug to prevent recurrence. So you may have heard of tamoxifen or something you take for 5 years or 10 years. We don't have that drug. And so my cancer came back after a year, as many triple negatives do. The other scary things is 40, and I think Dr. B mentioned that 40% of triple negative patients are under the age of 40. And it's just, it's horrible. I think, Black breast cancer is different. We have a different disease. We have a different triple negative disease. And some of the stats, and these guys have mentioned them, Black women have a 41% higher mortality rate of breast cancer overall. So think about that. For every 100 white women who die of breast cancer, 141 Black women die. That's insane. We have a 39% higher recurrence rate. And a lot of that is due to triple negative breast cancer because it comes back so readily. But the worst statistic is the young women factor. And both doctors have mentioned that Black women under the age of 35 get breast cancer at twice the rate and die at 3 times the rate. And these numbers are just abominable. And when I look back in history a couple of years ago to see what's wrong with the science, right? And when you look at the clinical trials that were done on all the drugs that we take that are standard of care, there were no Black women in those trials. So I think what we're seeing is that, the drugs aren't working for us. And even now with the drugs being developed, we only have a 3% participation rate. So frankly, we don't have the data that we need and the science that we need to understand this disease for overall, but definitely for Black women. So we have a lot of work to do to advance that science. But, it's just crazy, right? These numbers are crazy.
And for all of you then with, again, the talking about clinical trials, what is important? How can we move the clinical trials forward that are more diverse and more targeted to the right populations that are in greatest need, and kind of transition this from kind of last resort to more preferred therapy? I know there's many barriers to clinical trials, but what can be done?
I can start that one. So we did a research study a few years ago, and the main reason why Black women don't participate in trials is because the doctors aren't like these two lovely ladies. They don't invite us. And so we're not being invited. We don't know what they are. But really the biggest emotional barrier, and people want to blame it on the social determinants of health and the history of Henrietta Lacks and the syphilis study, but it's really a fear of the unknown. They don't understand what standard of care is. They don't understand that you're going to get a better quality of care and have better outcomes. And when you break the science down in very simple terms, like, that Advil you took last week, it was in a clinical trial. That heart medicine I gave my dog Harper, it was in a clinical trial. When you break it down for them in words they can spell, they want to sign up. They want to live. And so, we launched our campaign a year and a half ago just to educate Black women about the basics of how a trial works and what a standard, what standard of care is and what's going to happen in a trial. And frankly, if you're a Black woman, and I'm not a doctor, so doctors help me out with this, if you're a Black woman under 40 and you get triple negative breast cancer, a trial is really your best outcome.
It absolutely is. Yeah. And I'll just sort of address, let me just say, Ricki is just so phenomenal with the work that she has done and she continues to do as an advocate, thriver, warrior. Every time I see her, I am just encouraged to, continue to do the work that we do, front-facing patients to address. So everything she said is absolutely correct. To address the issue of physicians not offering clinical trials to minority patients. It is an atrocity. And the more we speak about it, the more that we hold healthcare systems to the fire, the hope is that we can move the needle. I will say at our institution, we did just that. We wanted to take away bias. And we know just from systemic racism, that has existed in this country, the healthcare system is built on bias and it's explicit, it's implicit, it's many different forms. And so how do we address that to ensure equitable access for all of our patients? And we developed a process where there were multiple layers and multiple opportunities for the patients to be made aware of the option of having or the availability of clinical trials, and that they should ask, right? You want to educate patients. So with the first intake call, we have clinical trials. Make sure you ask about it. We will offer it to you. It would be wonderful for you if you qualify, to as Ricki said, yes, the historical aspect, but to paint the picture, which is so true, that oftentimes patients on clinical trials receive better care, and to sort of, understand that, because there's more oversight of their care. And then when they come in for their multi-D visit, we have clinical trial team members who are present with all of the eligible trials who have done a chart check, not because the woman is Black or white or whatever. They've done a chart check and they figured out which eligible trials the patients are, they can present to the patients, and then they remind the physicians. And if the physicians don't do it, the clinical trial team members have the option of sort of pushing it up to me, and they don't, want to do that. We haven't had that issue. The patients give videos about it, right? We discuss it in our tumor board where we have all specialties present, and we have a template where all of the clinical trials are present, and we're not thinking about this person may have children, and all of the things that some of the physicians and providers come up with. Oh, I didn't offer it because I thought that it would be challenging for them to do X, Y, and Z. No, that's why we have social workers, right, and navigators who can help. So just to address that, I think if we as healthcare physicians and leaders, if we take the bull by the horn and really address that there is a bias, and how do we eliminate that bias? How do we take it off of one person and really make it a team approach? Then we can really, offer those patients the clinical trials that are available to them. So, and then the other sort of backup to that is when you sit at the table, you have to speak up, right? And so that means if there are clinical trials that are not going to be helpful for the community that you serve, then that we're not helping the community that we serve. And so we have to, make sure that we have clinical trials that are representative of the patients that we take care of.
I know we could talk about this, and we can come back to it in a little later in the session. I am going to move us along to our next presenter, panelist. And thank you so much, Ricki and Dr. Valencia and Dr. B, for this kind of opening conversation. We really have to, as you've identified, we need to find a way to better describe some of the research and development related to TNBC and these gaps you're talking about not really having trials or medicines that have been tested in these populations, and how critical of that. So we're going to shift to Dr. Melissa Davis, as I mentioned, from the Morehouse School of Medicine, and Dr. Lai will also be presenting from Gilead Science. The term triple negative breast cancer indicates kind of what it isn't, that it's not of these, but rather than what it is. And we know it's more of an umbrella term that has many subtypes, making it complex and necessitating highly personalized medicine to receive the best outcomes. Dr. Davis is going to talk to us about her incredible research in the genetic identification of TNBC. And I'll turn it over to you, Dr. Davis. Thank you so much for sharing this with us today.
Hi, wonderful to be here. Thank you so much. I know Dr. B and I call her Dr. Fairley because she is a scientist as well, very well. I also want to take a moment to introduce my research partner, Dr. Lisa Newman, who's the Chief of Breast Surgery. And the work that we do is largely even possible because of the work that she laid the foundation for. So, you know, we focus mainly on disparities, but I just want to drive a couple of points home that were discussed today and why we take the approach that we're taking. So we look for biological as well as social determinants of disparities. And we can define disparities in many different ways. You can be disparate by just basically saying that two different populations don't have the same outcome. So it could be gender, it could be age, it could be rurality. But in every type of cancer that we look at, we definitely see this disparity. Now, some of it is driven by social economic status. And so this map shows where poverty is across the country. So one of the reasons why we pivoted away just from socioeconomic status is because when we look at the mortality rate, particularly for breast cancer, the disparity emerged at the same time that the onset of endocrine targeted therapies emerged. And living in an affluent environment where socioeconomic status and barriers are not an issue, Black patients who live in affluent counties still have a higher mortality than white patients who live in poverty. And so that tells us that there are biological determinants, specifically tumor characteristics. And the way that triple negative breast cancer is defined, I just want to drive this home, is by the absence of these particular receptors, HER2, ER, PR, and this is what one of those diagnostics actually looks like. So all the way on the left, we see the negative stain would be a patient who has a triple negative. And so the brown represents what the drug would target if we're having endocrine targeted therapies. And so not having those three targetable molecules on the tumor puts people at a disadvantage because, as Dr. B mentioned, triple negative breast cancer is at the worst end of the prognosis spectrum, mainly because it's so aggressive. The molecular tendencies that we see mean that it's more aggressive. But in the Black population, triple negative breast cancer doesn't behave the same. So in all patients with triple negative breast cancer, there's a worse outcome potential. But particularly in Black patients, what we see is a much lower survivability, even in the same healthcare systems, where even for screen detected cancers, where we expect to see some difference between screen and non-screen detected tumors, because screen detected would be earlier stage. The Black patients, even who have screen detected cancers, tend to do worse than white patients with screen detected cancers. But we believe this is because the biology of that triple negative status is different in Black women. If we look at, for instance, the actual genes that are expressed, so I'm showing you data here. The colors blue and yellow represent sets of genes and whether they are highly or lowly expressed. And when we compare the tumors of people of African descent to the tumors of people of white or European descent, we see different genes expressed, which means we could possibly be seeing other types of cancers within that umbrella of triple negative breast cancer. One of them is quadruple negative breast cancer. So Black women tend to have a quadruple negative status, which is just another absence of another potential target, which is androgen receptor. But this earlier onset, particularly in Black women, where their onset is, you know, in their 40s, right? We see a peak of this particular subtype in their 40s, as opposed to white patients having a spike in this particular type of cancer later in life after 45, but mainly around 50, is an indication that there could potentially be a shared genetic driver. We believe that has something to do with our ancestry, because most of the people who are in these admixed populations in the Americas and in the Caribbean and even in Europe are descendants of this gene flow that occurred over centuries. And Dr. Newman observed that women in West Africa had a higher rate of triple negative breast cancer than women in East Africa. We went on to even show that in any nation where we can separate Black versus white or African versus European, it's the African component of the population that has the highest rate of triple negative breast cancer. The highest rate globally is in sub-Saharan Africa. So we are looking for that African connection. What is it about the genetic background? We measure genetic ancestry in our large cohort of thousands of women from across the globe, including Africa. And we've shown that West African ancestry is associated with having a higher rate of triple negative breast cancer. And all that really means, because like when you give your DNA to 23andMe or Ancestry.com and they give you this nice pie chart, what they've done is looked across all of your chromosomes and they've found the different regions of your chromosome that originated from a specific continent, right? And so when we are measuring just the West African component and we see an association with triple negative breast cancer, what this means is that there's some locus on some chromosome, we don't know which one, but the genetic background happens to be African. So it's a variant of a gene or maybe a set of genes that's driving this particular biology of an unknown mechanism. And it's unknown to us because we don't study this population enough. The majority of the data that exists for genomic research has originated from European ancestry, which leads then to anyone of non-European ancestry having a higher likelihood of a test result that's an unknown, for instance. So these are inaccurate clinical tools. And so the way we want to bridge the gap is filling the gap with more knowledge about the African diaspora, the genomics of African diaspora, doing a better job of defining what these unknowns are, because it doesn't have to be unknown. We should know exactly what these particular genetic variants do. And in the work that we published in very high-tier publications indicates that the diversity in African Americans represents every region of Africa. So that's what this colorful diagram shows, and that in our African Americans, every region of Africa is present. And when we look at what those genes are that are associated with African ancestry, what we find in our unique way that we do this analysis is the difference in gene expression is really related to immunological responses, but we even see imprints of the social effects. So for instance, diabetes, obesity that's higher in African Americans because of marginalization, all of that gets imprinted into the genetic signatures and the gene networks that are expressed in these tumors. And so that's primarily why we think the tumors don't behave the same, even though we're giving the same standard of care across the board. A certain group of people who have a different experience, who have a different genetic background than what was used to define our understanding of the biology of these tumors, just simply have a different type of disease course because the biology of their tumor is still too understudied. Right. So moving forward, what we're trying to identify are novel targets and just a better understanding of why the biology is different, either from a genetic perspective or from, a social environment exposure perspective.
Great. Thank you so much, Dr. Davis. Fascinating work. We could spend a whole session on that, I'm sure, to continue to learn more. I'm going to turn it over to Dr. Lai about to talk about the strides that have been made in triple negative breast cancer research.
Hi, thank you for that, and I have to upfront thank this great panel. I'm learning a lot from the different folks on the panel, so thank you for that, and also to ask for a little bit of compassion here. I think a minute before we started, my power went out. So I'm kind of running a perspective, but hopefully that isn't too apparent. We have a few slides that I think someone was going to help put up for me, and if it's not available, then that's fine as well. But maybe what I can do is just talk through what we're hoping to show from a slide perspective. In terms of breast cancer, as Dr. Davis has shown, and others on this panel have discussed, triple negative breast cancer really has historically been a diagnosis of exclusion, meaning a breast cancer subtype that is lacking in hormone receptor or HER2 receptor expression. And this really is an oversimplification of what really is triple negative breast cancer. And certainly we view this as more of a breast cancer subtype that is made of actually many subtypes. From a clinical research perspective, or even a treatment perspective, sometimes we think of this as triple negative being defined more by what cannot be used to treat this devastating disease, as opposed to what can be used. And we see, as we've seen here, that as such, because we don't have great targeted therapies, and this disease is so aggressive, patients with triple negative breast cancer tend to have poorer patient outcomes compared to other types of breast cancer. So it's ongoing investment essentially in the research of the biology of triple negative breast cancer and new medicines that can help us to better focus upon how to define types of triple negative breast cancer and what essentially can be used to treat each patient. I cannot see the slides on my screen, so if we can move to the next slide, talking about recent approvals, we can certainly see that, you know, investment in triple negative breast cancer has been relatively limited until only, I would say, in the past 10 years or so. But we're recently being able to start to see the fruits of this initial investment in understanding triple negative breast cancer. We've identified biomarkers or targets that are more relevant to triple negative breast cancer recently. These biomarkers such as a PD-L1 or TROP2, and how these targets can help us identify molecules or drugs that can better treat patients with triple negative breast cancer disease. And you can see here some approvals in the past few years of drugs or drugs such as PARP inhibitors, cancer immunotherapeutic agents, and more recently, a type of drug called antibody drug conjugates. We've had 2 agents approved that can help patients, or some patients, with triple negative breast cancer. And it's been really exciting to see these advancements in recent years. And so we've been able to slowly find more agents that give patients with triple negative breast cancer more options. If we move to the next slide, it's despite these advances, though, there's really a lot that still need to be done. And where I get excited as someone who is in cancer treatment research is seeing how we can bring even more effective drugs to more patients. And what that actually means to me is more from the perspective of how do we enroll patients from historically underrepresented populations into our trials. And what I mean is through thoughtful clinical trial design and execution. And that may seem like a really high level description, but what I mean is really starting from the very beginning of a study conception, right? Talking to patients, healthcare providers to understand how do we best reach patients that are not typically representative in clinical trials. We've partnered with patient advocacy groups, for example, to understand how do we make our studies more attractive, less burdensome to different patient populations? How do we select sites that we may have not typically selected in the past to make sure that we're bringing clinical trials where the need is, right? Or where we can better understand the science. So that's really exciting to me. But even beyond that as well is by studying drugs that we think are effective in earlier lines of therapy, meaning that if we have some drugs that we see are effective in, say, late stages of disease, how do we bring those drugs earlier, so we have a better possibility of bringing broader impact to patients with triple negative breast cancer, and maybe even bring it to a setting where we can actually even conceive of the idea of potential cure, which is not something that we typically hear, right, when we talk about triple negative breast cancer. So from that perspective, I think there's still a lot more that can be done. If we move to the next slide, when we're talking about bringing new drugs or better drugs to patients, I think really what we're looking is really continued investment in research so that we can help to identify new molecules or new drugs, new types of platforms, so that we can provide better options for all triple negative breast cancer patients from all backgrounds. And that could be either drugs that increase our ability to kill tumor cells directly or indirectly through harnessing our own immune system to fight against cancer. So with these explorations of new mechanisms and by better understanding the biology of triple negative breast cancer across all different patient types, we can hopefully identify differences in triple negative breast cancer patients that can make a difference in how we tailor treatments and better improve outcomes for triple negative breast cancer patients. So thank you.
Great. Thank you, Dr. Lai. That was very helpful. It's exciting to think about where the science is going and knowing that we still have much work to be done there. So let's bring all our panelists back together again and kind of pull all these things together. We've talked about, you know, barriers to screening and diagnosis. We've talked about the lack of targeted treatments to treat TNBC or to prevent recurrence. We've talked about inadequate representation of Black, Latina, in particular women in clinical trials, and that's a complex issue. And we've also talked about the genetic factors that make it kind of increasingly complex for research and moving the needle in treatment. And we've talked about some of the promise of where science is going, but you know, so but yet we need to maybe spend these next few minutes talking about solutions and what can we do? What can the community do, the greater oncology community do to reduce these disparities? And we know that it is complex issues and there's no one size fits all, but based on our conversation thus far, what are some of the solutions to address the barriers impacting things like early diagnosis, survival for women affected by TNBC, getting them to clinical trials, anything you can think of from either a patient, survivor, thriver perspective, a physician, a researcher perspective? What are some of the solutions that we could talk about today that either you're working on or that you'd like to see happen? Ricki, did you want to start?
Yeah, I have a solution. When I think it's a huge thing, right? But to me, we're not going to make the inroads that we need to make without the science. And we're not going to get the science unless we have the patients in the science. And so that's where I focus. I can't change racism. I can't change doctors not inviting us, but I can educate women to participate in the science. And I know that our When We Trial program, our movement that we started a year and a half ago, in the past year, we've now signed up almost 14,000 Black women into clinical trial portals. So I know that our messaging is working and that we are convincing women to change not only their mindset about clinical trials, but also the behavior because they're signing up. And we need more of that. The other thing that we're doing is we're partnering with our pharma partners that are like Gilead and, you know, the companies making the drugs for triple negative and for all breast cancer for Black women, and participating in the development of the trial. So we've been designing trials and rewriting the communication of how we talk to patients to engage them in trials, and, you know, saying, okay, your baby is ugly, sorry, we're going to throw this brochure out and make you a new one. And I've been very aggressive about that. I have no shame. And the other thing is we have a nurse navigator on our team, and her role is basically to help patients. You know, when a patient gets that sort of nibble, I want to try it, we call them, we talk to them, we talk them off their ledge, explain the informed consent to them, to their families, and then provide this sort of fairy godmother nurse navigator program to help them through the trial to stay in it. And so we're not part of the research team. We're not part of the pharma company. We're an advocacy group with a breasty navigator who can talk to the patients and basically motivate them and keep them up and happy to stay with the trial. So, I think if we get more people into research, and my purpose is to get more Black women into the research and keep them in it so we can get these, scientific solutions that we need.
Great, thank you. Dr. Valencia, did you have any thoughts about how we could start to make a difference?
Yes, thank you. I agree with my colleagues. It's great to name the problem, declare it, and then to collaborate to address and formulate solutions. I can't emphasize enough the great work that NMQF is doing in leading this effort, because it's declaring and naming the policies that are going to help us refine our strategy to improve the quality of our results. And part of what they're doing is they're at the table with the Cancer Shift Initiative, with the Cancer Moonshot, with the White House. And it's so important that we're all aware of this, that we come together and support this effort, because we're talking about changing the game in terms of earlier detection, earlier diagnosis. But what's the point of identifying it if we don't know how to treat it? So that's where all our partners in pharma industry, all our researchers, medicine has the science is a true collaboration. So it's as a breast imager, I can find your cancer, but if we don't have a way to treat it, how are we really changing the outcome? And so it's the formulation of really investing in the areas that are targeting and that are geared to change the outcomes and the impact. We want to be able to find triple negative cancer in younger women. We want to be able to find it in women that don't have access to standard of care treatment and offer them the clinical trials. But those that are having recurrence, we still need better ways to help them in their survivorship, to cure them, and to prevent it from becoming at a more advanced stage. So all these things are important, but even if we bring that A game, we have to be able to partner with our communities. They have to be able to trust us. So I step back, and when I teach the fellows and residents and medical students, or I'm talking to the community, is what good is it if I have all these resources, but you don't trust me and participate and take these up? What good is it that we have all of this? And a good example is in breast imaging, we have ways to find cancers earlier in dense breasts, and so patients in our 20s and 30s. But these new technologies are not available in every community because of the expense, because insurance doesn't cover it. So we're back to access issues. We're back to, do we have the expertise? Are we disseminating best practices to our colleagues in the community? Are we forming safety net partnerships? And how are we at the same time investing in creating trust with communities and patients in a way that actually eliminates the disparity, so that there's actually equity in the diagnosis of breast cancer and in the treatment? Most marginalized or underserved communities aren't being offered clinical trials because they're not near a center, or they don't know about it. How do I do that in a community if I don't have insurance, if I'm not likely to go to an academic center? So the work that Ricki's leading and many other colleagues and partners are leading is so important, and we have a long ways to go. But I just wanted to summarize, it's all about early detection, early diagnosis, effective treatment, and partnership and relationships. It comes to trust in it. And the leading effort for all that is policy. Policy is going to guide all these pieces to change the strategy and to change the outcome. And so that's why NMQF doing this work, the cancer, shifting the cancer stage initiative, is critical to the work we do. Thank you.
Oh, thank you, Dad. I don't want to, we have just a few more minutes left, and I'd like to dig a little bit more into that policy. if we're really to create some sustainable change, and we look at how can policy reform really play a role to prevent or mitigate this negative impact of TNBC on the Black, Hispanic, and young community? Where can that policy change really take place? What do you have some thoughts about what we could be doing in policy to improve that?
Yeah, so I think there are multiple layers of using policy to really inform how we treat and address the disparities that we see in this country. For breast cancer, just to go back to the trust that needs to be built, it absolutely needs to be built in communities. And one effort that we focused on was the screening part of it. And we know that there are guidelines that exist that don't completely take Black women in mind, such as the USPSTF guidelines that recently just changed, that are still not completely where we think they need to be. So to kind of quickly summarize it, all women who are at average risk should get a mammogram at the age of 40. USPSTF still recommends that screening happen every other year. Now, if we're saying that triple negative breast cancer can be diagnosed and is aggressive, or I should say is just aggressive, then skipping 2 years is not ideal. Also, how do you determine average risk? I mean, we just kind of just throw it out there and everybody's supposed to know what average, if you're average risk or high risk, right? And so we've just kind of blindly thrown out this term without really ways of addressing average risk. So I think policy can be informative to really do what the American College of Radiologists are recommending, which is to determine risk assessment at the age of 25. And not everybody knows that, right? But we also have pushback from insurance companies. I argue with insurance companies every Friday. It's my day to call and do peer-to-peers, and it's an incredible waste of time. But I do it for my young patients who are at high risk, who do need MRIs, who do need screening before the age of 40. And so I think from a policy standpoint, screening and being able to diagnose this earlier is important, especially given the statistics that we talked about previously.
Thank you. And Dr. Valencia, we did have a question from the audience. How can improved coding contribute to really shifting this making a difference?
Thank you for that. I just want to agree with my colleagues here that data is important. The coding will allow us to have this longitudinal data analysis. We're able to see if we have a code for triple negative breast cancer, which NMQF is leading this effort in this policy change at the federal level, it will allow us to have the data at our fingertips. And that longitudinal analysis will help guide investment for research, for breast cancer research, triple negative breast cancer research. And it will also help us to pull out the demographics and the data and then tie all those relationships to the clinical outcome. It'll elevate the game in terms of it will center the triple negative breast cancer patients that have long been marginalized by our current coding system. It sounds like a low lift, but it's a significant lift that's currently being led by NMQF. And we really are hoping to see some monumental change in that regard for coding in the next few months.
Thank you for explaining that. I'm wondering of the panel, is there, I've heard concern among the advocacy community and the patient community about the possibility that the Inflation Reduction Act, IRA, could impede medicine development, and particularly in rare cancers like TNBC. Any thoughts on that from the panelists as to, how, if that is an issue and how we should be thinking about that for policy reform?
I think maybe I can say a few words from my perspective. I think certainly, as our panelists here have mentioned, right, there's a continuum here and a partnership, right, in terms of identifying patients early, diagnosing them, but at the end of the day, do we have the medicines available to treat these patients, and identifying new biomarkers to impact a diverse patient population is critically important. However, there's a significant amount of investment that needs to occur there. So any anything that can impact the ability to invest in these clinical trials or in biomarker research is going to impact, whether or not we're going to be able to bring valuable, beneficial treatments to patients of all types. And most importantly, for triple negative breast cancer, really bringing effective medications that can bring great benefit, survival benefit, et cetera, to a smaller patient population, that's going to be super critical. So anything that would be able to impact how we invest in this patient group is going to have impact on how we're going to be able to move the needle in outcomes for triple negative breast cancer.
Thank you, Ricki.
I'll just add, I hate the word underserved, because I think it's just a horrible word for patients. But I do worry about the unsupported and how much we are part of the information, or part of the study, or part of the work that people are considering. People, the fact that we are a small audience is not good enough. I think that we have to be considered in every aspect of policy. And so many of these women are unsupported and don't have good care and don't have good access to care. So anything that can help us have better care is critical for policy to consider.
Thank you. And kind of one last question to the audience, to the panelists before we wrap today. If you could wave a magic wand, what change in our healthcare system would better support women impacted by TNBC? And I realize that could be like another session in of itself, but maybe if you could just think of a couple of words, what if you could really make a change, what would you like that to be? And Dr. Davis, would you like to start with that?
Sure, and I'll blend my response from the last question to this one, because I think it actually is related. So, we talk about policy and biomarker testing, for instance, and if we have a standard that requires better definition of triple negative breast cancer, if we translate all of the technology that's been developed in the science and research development space into the clinic space, I think that would begin to empower a translation of better targeted therapy. But even if not, just simply repurposing things that are already available, because we have an arsenal of therapeutics that are potentially useful in certain subtypes of triple negative breast cancer, but we just don't know what they are in terms of individual patient diagnoses. Like, we do whole genome testing, but not for the same purposes of diagnostics. And so this comes back to biomarker policy. So if we can enact a biomarker policy that's required to better distinguish, so differential diagnosis of triple negative breast cancer, I think that would change the paradigm.
Great, thank you. Final comments then, your magic wand to change the healthcare system, Dr. B.
So you made it complicated, because I have a whole list of things, but I think improved access to everything, right? Make the playing field even, and that's what we need to strive for across the board. So I know we're running out of time, so I'll leave it at that.
Any final thoughts before we wrap then, panelists? Thank you so much. Again, we've learned, just to quickly summarize, we've learned that to change the game in the identification and treatment of triple negative breast cancer, better risk profiling, removing practical barriers and access barriers to screening, but also to quality care that's appropriate, navigation services to get patients to the right screening and the right treatment and the right support across the continuum of care, and really investing in we can't move the science, as Ricki said, without having Black or Hispanic women in clinical trials. So learning loud and clear about the continued investment in research and development. On behalf of everybody facing both patients and providers working in triple negative, thank you so much for attending today, and for the National Minority Quality Forum for supporting this effort. And we're really appreciative of all your support. And if you'd like to get more involved and learn more about how you can make a difference in TNBC, please reach out to Touch, the Black Breast Cancer Foundation, to see how you can help, because TNBC can't wait. And we're really pleased and honored with these panelists today, and to bring this important information to a call to action. This concludes our webinar, and thank you all for joining. Have a wonderful weekend and be safe. Take care. Bye-bye.
Thank you.
Thank you.
Thank you.